And hello to our audience. Thank you for joining us today for our webinar, Evolve the Nerve, Autonomic Nervous System Issues in Parkinson's Disease. These series of nursing webinars showcase the work of our nurse scholars who have completed the Edmund J. Stafford Visiting Nurse Faculty Program at Parkinson's Foundation. Today we have two excellent speakers joining us, Joan Gardner and Janice Beitz. I will be telling you more about our distinguished speakers shortly. First, however, a little bit of housekeeping. The PowerPoint slide deck can be downloaded from the reminder email you received this morning or from the Parkinson's Foundation webpage highlighting this talk, or on the page you are looking at to the left. Health professionals can earn one free CEU through the American Society of Aging. Participants will receive an email after today's webinar with steps on how to collect the one CEU. You have just 30 days when the CEU is available, that is, until April 26th, to collect the free CEU. However, please note that you may view the webinar at any time after that on our archives. So it is my pleasure today to introduce you to our topic and introduce you to our speakers. As I mentioned, the topic is Evolve the Nerve, Autonomic Nervous System Issues in Parkinson's Disease. Next slide, please. In way of introduction to Parkinson's disease, I just wanted to mention briefly, and most of you probably know this that are listening, that Parkinson's is a progressive neurodegenerative disorder and affects approximately 1% of people over the age of 60 years. That translates to an approximate 0.3% of the general population in industrialized countries. There are 1 million Americans affected by Parkinson's disease, and in the U.S., 60,000 new cases yearly, while worldwide there are 10 million people suffering from Parkinson's disease. It's very common in that it is second only to the most common neurodegenerative disease, which is Alzheimer's disease. And while men are affected slightly more than women, there is not a huge discrepancy, perhaps 1.5 times more than women. As we know, there are motor symptoms and non-motor symptoms present in Parkinson's disease. Probably the well-known motor symptoms known to all of you: tremor at rest, rigidity or stiffness, slowness of movements or bradykinesia, and postural instability. However, patients also experience a myriad of symptoms that are non-motor in nature, and they fall into categories such as cognitive, neuropsychiatric, sleep, and autonomic issues. When we talk about autonomic, we're thinking particularly of those issues that affect the bowel, the bladder, the cardiovascular system, the gastrointestinal system, and the skin, which is the largest organ in the body. So our objectives for today's presentation are to discuss these common autonomic issues in Parkinson's disease, including those affecting the cardiovascular, gastric, bowel, bladder, sexual functions, and skin, which is also called the integumentary system. We're going to talk about that, and issues in the skin include things like seborrheic dermatitis and hyperhidrosis, or excessive sweating. We will talk and identify additional skin issues related to Parkinson's disease, including melanoma, skin reactions to medications, and other issues that affect the integumentary system due to problems with mobility. At this point, I would like to introduce our first speaker. Joan Gardner is the clinic supervisor at the Struthers Parkinson's Center in Minneapolis. It is nationally recognized for its comprehensive interdisciplinary approach to the management of Parkinson's disease and related movement disorders. She is also the coordinator of the Parkinson's Foundation Center of Excellence at this location and is responsible for the management and advancement of interdisciplinary team programs. Joan is very committed to increasing awareness of Parkinson's, improving care for individuals with Parkinson's, and supporting care partners. She has co-authored numerous publications and resources, including the Parkinson's Foundation Care Map and the Companion Care and Coping Workbook. Identifying the need for improved health professional education about the unique care needs for Parkinson's, she has co-developed the educational and outcome-based Struthers Parkinson's Care Network, which is comprised of senior residential communities and home health agencies in multiple states who have made a commitment to improve the care and provide support for those living with Parkinson's disease and their families. Joan has served as nursing faculty for the signature program of the Parkinson's Foundation, which is called the Allied Team Training Program for Parkinson's disease. And she has been a host site coordinator for the Edmund J. Saffer Visiting Nurse Faculty Program since the year 2012. Welcome, Joan.
Thank you very much, Gwen, for that kind introduction. So let's begin our discussion today just with an overview of the autonomic nervous system. We know that it's a control system that acts largely unconsciously without voluntary input. We also know that Parkinson's disease affects autonomic innervation to several organ systems, including the cardiovascular system, urinary, GI systems, and that thus affects heart rate, blood pressure, sweating, sexual function, GI, and urinary function. Research indicates that about 90% of people living with Parkinson's disease experience autonomic symptoms. Often, when you talk with folks living with Parkinson's disease, they relate that these symptoms are more bothersome than the motor symptoms that Gwen described and really have a negative impact on quality of life. And then you'll hear this several times, but side effects of PD medications will worsen autonomic nervous system problems. So non-motor symptoms can occur at all stages of Parkinson's disease and really lead to social isolation, decreased quality of life for patients and family, and increased caregiver burden. And despite increased awareness of non-motor symptoms and a high burden for people with Parkinson's disease, non-motor symptoms are frequently neglected. With the large number of nurses in the workplace worldwide, nurses have the opportunity to play an important role in raising awareness of non-motor symptoms and in educating multidisciplinary teams in a variety of settings, in the hospital, in care communities like assisted livings and long-term cares, and in outpatient clinics, but also in educating a lot of people and families living with Parkinson's disease, the general community, and again, healthcare professionals of all disciplines, including prescribing clinicians who really may not have an awareness of the impact of non-motor symptoms, autonomic nervous system changes on the individual living with Parkinson's disease. Also, we have to consider that medications that we use to treat non-motor symptoms really complicate the medication regime and add to family costs. It's important that nurses work with the interdisciplinary or multidisciplinary teams because they need education on the role of the nurse in PD care and how nurses can influence efficient and effective care for those living with Parkinson's disease. So the first area that I'd like to discuss is that of changes to the GI system. And let's start with slowed gastric emptying. Slowed gastric emptying can occur at all stages of Parkinson's and is often not recognized and can contribute to a development of many upper GI symptoms: nausea, vomiting, heartburn, bloating, gas, early satiety, weight loss, even pain. There is a potential for retention of levodopa in the stomach that can delay its absorption, thus prolonging off time, resulting in discomfort and poor health-related quality of life. Slow gastric emptying does not improve with medications that we give for Parkinson's disease, and in fact probably contribute to gastroparesis. Unfortunately, treatment is limited in that most commonly used drug, Reglan, is contraindicated in PD. It blocks dopamine, and obviously we don't want to give that medication. Domperidone, available outside the U.S., is thought to be effective and safe for this problem. So how do we manage slow gastric emptying? Small, frequent, low-fat meals, encouraging regular exercise. For nausea, holistic therapy like ginger ale, crystallized ginger, even ginger essential oils rubbed on the skin can help nausea. A big nursing role is to monitor weight, educate regarding how to maintain or even gain weight. And the use of over-the-counter medications can often symptomatic relief, and these would be the same medications that anybody might use for acid reflux, as well as gas, over-the-counter medications for gas. I want to add that nurses can also teach patients to monitor their PD medications using a symptom diary to look for patterns of delayed on, incomplete on, or dose failure, and that might be help us to get a most effective treatment regime. We're going to now go into really the most common problem with the gut for people with Parkinson's, and that's constipation. And we all know that constipation is fewer than 3 bowel movements per week, or having to really strain to pass stool. Constipation is a symptom that occurs before we see the motor symptoms in Parkinson's disease and affects about 80% of those living with Parkinson's disease. Healthcare workers should anticipate constipation when they work with people with Parkinson's disease. Constipation is divided into 2 types. The most common, and the one we're focusing on for this conversation today, is that due to slow colonic transit. It's interesting that colon transit time is doubled in individuals with Parkinson's disease compared to the general population, and that constipation is a frequent cause of urgent care and ER visits, which obviously is really distressing to the patient and family. Constipation due to sphincter control and coordination of many muscle groups leading to incomplete evacuation and pain. And again, we're not going to focus on treatment strategies for that. And as we said previously, Parkinson's medications contribute to constipation, and that it's a side effect. So successful bowel regimes are as important as Parkinson's disease medication management for individuals with Parkinson's disease. Make sure to ask about constipation in your assessments. It's easier to prevent than to treat. Bowel regimens are successful because of patient understanding that bowel function improves with improvements in diet and nutrition, with adequate fluid and regular exercise. And so listed here, you'll see some management strategies, and I think nurses are really very, very familiar with all of these strategies. The constipation recipes, senna fruit paste or power pudding that contains bran and applesauce and other things that just try to encourage motility of the gut. Pear, prune juice, yogurt, probiotics. Again, regular exercise is really, really important. What I do want to say that if the diet alone doesn't help, most people I know living with Parkinson's have to take some kind of medication, and the over-the-counter medications usually work very well. Polyethylene glycol, or Miralax, is the medication recommended by the American Academy of Neurology to treat Parkinson's constipation. And the other thing I want to add is you all know that if bulk laxatives are taken with decreased fluid intake, then you're going to make the problem worse. So if somebody is on that medication and it's not working, then we should probably switch them over to Miralax. And there are prescription medications like Ameza or Linzess that can be used to help manage this problem. The second problem that I wanted to talk about is that of orthostatic hypotension. And we know that by definition, that is the failure of the autonomic nervous system to regulate the blood pressure when we change positions. And again, by definition, orthostatic hypotension is a drop in blood pressure with position changes of greater than 20 millimeters of mercury systolic and 10 millimeters of mercury diastolic within 3 minutes after standing. It's interesting that it may be present in up to 60% of people with Parkinson's, but not all are symptomatic. We usually see symptoms occurring with a systolic of 80 or less, but not always. And also, if somebody is asymptomatic, it's an opportunity for nurses to do behavior modification teaching because they may start to develop symptoms because prevalence increases with disease duration, severity, age, and levodopa dose. The symptoms of orthostatic hypotension I think you're probably familiar with: dizziness, lightheadedness, syncope, but they also may experience blurred vision or foggy thinking when they're up and about, that coat hanger type of headache, or lethargy. Symptoms may fluctuate throughout the day or even day to day. And again, we know that there are many reasons that people might develop low blood pressure, and so it's important to rule out other medical causes like hypovolemia, anemia, check for other antihypertensive medications. Because a side effect of levodopa and other PD meds is low blood pressure, when an individual has low blood pressure, it limits the ability to add PD medications to manage symptoms. So that is a very difficult thing for individuals living with orthostatic hypotension. And then please remember that caregivers have increased burden and concern regarding symptoms and management of low blood pressure. This is just a diagram that I like that shows that we all have the lowest blood pressure when we awaken in the morning. So let's think about what kind of implications that might be when nurses or nursing assistants are getting people out of bed in the morning. Blood pressure fluctuates throughout the day, but please note the drop at mealtime. Postprandial hypotension is common when the blood is really in the gut digesting a meal. And also with a large fluid or urine output, we can also experience blood pressure drops. So what do we do about orthostatic hypotension? First of all, if your patient complains of dizziness upon standing or foggy thinking when walking, go ahead and check that sitting and standing blood pressure readings. Take the standing after that somebody is up for 1 minute. It's important we take a look at the overall medication list, certainly for antihypertensive meds, but other medicines that might contribute to dizziness or low blood pressure. Let's, again, the behavior modification strategies you're all probably familiar with: the slow sit to stand, the moving legs in the bed or chair prior to standing, that increase in fluid intake daily. I understand that drinking 8 ounces of water before exercise, or if somebody drinks coffee, they should add another 8 ounces of fluid to their daily intake. Increasing salt, if not medically contraindicated. Small frequent meals is a wonderful strategy. Avoiding hot showers and baths. Athletic spandex, shorts, Spanx, or support stockings are very helpful. But oftentimes, we also need to manage constipation to avoid straining. Referring to our multidisciplinary colleagues of occupational and physical therapy for adaptive strategies and for safe exercise options is an important thing to do. Oftentimes, despite all these measures, medications need to be added, and we mainly use fludrocortisone, midodrine, or a newer medication, droxidopa. Bladder changes is the next change that we want to address. The next autonomic nervous system change occurs in a quarter to 50% of people with Parkinson's disease, and again, present at all stages. Again, two categories of bladder changes. The first is the most common, the irritative or symptoms or problems with urine storage, and is caused by detrusor muscle hyperreflexia. So this means that this overactivity of the detrusor muscle causes contractions to occur even though the bladder is not full, causing an inaccurate sense of bladder fullness, resulting in the need to void more urgently or frequently. Sometimes these contractions are strong enough to override the normal sphincter control and allow leaking of urine, resulting in urge incontinence. The second type of bladder changes are obstructive symptoms, and these symptoms are related to detrusor hyporeflexia. This causes weakened contractions, decreased sensation during filling, and actually increased bladder capacity. Symptoms include urinary hesitancy, difficulty initiating a stream, all due to weak or absent contractions. Overflow incontinence can occur when the bladder overfills, but there is no sense of the urge to void. In a woman presenting with obstructive symptoms, you'd want to rule out a prolapsed uterus. And in a man, you'd want to rule out an enlarged prostate. And the enlarged prostate is the most common symptom of bladder changes in men. So again, next we want to talk about what are our management strategies. So first of all, recognize that changes in bladder functions may be really difficult for people to talk about. Urological dysfunction affects quality of life, and obviously urine leakage or incontinence contributes to depression, anxiety, and usually results in social isolation. Also, poor mobility can complicate symptoms of urgency and nocturia and incontinence, and this increases caregiver burden. The non-pharma approach that could be used by nurses would be, again, things that you're all familiar with, scheduled use of the bathrooms. The clothing that's easy to pull up and down is especially important for people with Parkinson's disease because of their slowness of movement and the time that it takes them to get everything adjusted so they can sit and use a toilet. Pads and catheters, decreasing bedtime fluids, PTs, there's nice evidence about the help of pelvic floor exercises, and referring to OT or PT for bed mobility or transfer strategies is important. And pharmacological treatments, the thing I want to point out is that most of them are anticholinergics. There's only one bladder medication that is not an anticholinergic. So we all know the risks of anticholinergic use in the elderly. And so I encourage you to evaluate whether an anticholinergic is effective in controlling bladder symptoms if one of your patients is on one of these medications. I want to just digress for a moment from our autonomic nervous system conversation to talk a little bit about the importance of adequate hydration. It can obviously lead to hospitalization, bladder infections, and we know that low fluid intake will influence blood pressure, constipation, and skin. Dehydration in Parkinson's disease can occur for a variety of reasons. Many limit fluid intake to try to decrease the frequency that they need to go to the bathroom. And also symptoms of Parkinson's may make it difficult for somebody to lift a glass to drink or to get a beverage or to ask for a beverage. And they might refuse thickened liquids, thereby just not getting enough fluid intake. So management strategies are, my latest that I like is really asking people to drink 8 ounces of water with each Parkinson's pill dose, because people take Parkinson's pills several times a day. Smoothies, sorbets, those foods with high water content are important, and then referral to the multidisciplinary team of speech therapy for swallowing compensations or food modification, or OT for adaptive supplies. The last area that I wanted to talk about today is changes in sexuality or sexual dysfunction. So people living with Parkinson's disease may face concerns about its impact on their ability to have and to enjoy sex. Impaired sexual function occurs more frequently in people with Parkinson's disease than the general population, and there is decreased sexual activity with increased severity of PD symptoms. Changes in sexuality can occur for many, many different reasons, including depression, which might limit interest in sexual activity, physical immobility or difficulty moving in bed or pain when moving, autonomic nervous system changes like that of the bladder or even of the skin, changes in thinking, inability to communicate needs, or other medical comorbidities like diabetes or hypertension. The statistics for sexual dysfunction in PD are 81% of males may have erectile dysfunction, premature ejaculation, dissatisfaction with their sexual life, difficulty reaching orgasm, or difficulties with ejaculation. 43% of females with difficulty with arousal, reaching orgasm, low sexual desire, again, dissatisfaction with sexual life, or even painful sex. PD drugs are not associated with impotency or loss of libido, with the exception of anticholinergic medications. However, people with Parkinson's taking dopamine agonists might develop hypersexuality, so we need to make sure to talk about that potential problem. And various other medications, as you know, might contribute to changes in ability to have an erection or to reach orgasm. So the first step is to talk about sexual issues, and that is way easier said than done. Sexual health should be as much of a conversation with the healthcare team as any other health matter, but patients and patients' partners and healthcare providers may not be comfortable with a discussion about sex. So we also have to remember that intercourse is not a necessary ingredient to sexuality, and expressing love and affection in other ways is very important. Referral to a sex therapist if you know of one or have one on your team it is very, very helpful. So to summarize, autonomic nervous system changes are common in people living with Parkinson's disease, frequently not addressed, not documented, undertreated, and their importance to well-being underestimated in all medical settings. It's really important for nurses to be aware of these potentially debilitating symptoms and to include questions about them. Early recognition and assessment, education, and a treatment approach using a multidisciplinary team will likely lead to better outcomes and positively impact quality of life. A nurse can easily assist with determining interventions that work and that the patient will do. And then, of course, not forgetting the care partner and the added burden they have in managing autonomic nervous system problems. Also, remember, we can't assume that care partners know how to manage these symptoms. They really need education. These are just some references for my material. Thank you.
Thank you very much, Joan, for covering such a wide variety of the autonomic issues in Parkinson's disease, including the cardiovascular, the gastrointestinal, gastrourinary, and sexual dysfunction. That was a very good review of very, very important issues. Our next speaker will address the autonomic and other issues that affect the skin in Parkinson's disease. But before I introduce our next speaker, I would just like to have you note that questions can be submitted at any time by clicking in the text messaging box in the bottom left corner, type your question, and then hit the send button. We will have a question and answer period after our second speaker, who I will introduce now. Dr. Janice Beitz is Professor of Nursing in the School of Nursing, Camden, Rutgers University. She is the director of the Rutgers University Camden Wound Ostomy Continence Nursing Education Program and has taught nursing students at the baccalaureate, master's, and doctoral levels. Dr. Beitz has received many awards for her distinguished work, among them the Wound and Ostomy Society Nurse of Distinction and the President's Award of the Northeast Region. She's also received the Masters of Wound Care Award of the American Professional Wound Care Association. Dr. Beitz is a fellow in the American Academy of Nursing and in the National League of Nursing Academy of Nurse Education Fellows, as well as the National Academies of Nursing Practice. In 2014, Dr. Beitz was selected a Walter Rand Institute Faculty Fellow of Rutgers University to study diabetes challenges in the Southern New Jersey region. Dr. Beitz was a nurse scholar of the Edmund J. Safra Visiting Nurse Faculty Program in 2012 and published the first known nursing article on Parkinson's disease skin-related problems. She has presented her work on Parkinson's disease, skin and wound issues at the Northeast Regional Meeting of the Wound and Ostomy Nursing Association, the National Society meeting, and also published in the Journal of Ostomy and Wound Management. Welcome, Dr. Beitz.
Thank you, Gwen. I'm really honored to do this presentation, and I get to speak about a topic that's near and dear to my heart, which is skin and wound care and the application to Parkinson's disease as a result of my participation in a wonderful program. The Visiting Nurse Faculty Program is just superb, and I'm just honored to be invited to this session. I'd like to talk about some of the issues that go along with skin and wound care, and we're talking about particularly autonomic skin-related issues, and they include things like seborrhea, dermatitis in various forms like moisture-associated skin damage or incontinence-associated dermatitis, hyperhidrosis, which is excessive sweating, and then other integumentary issues like melanoma, a very serious issue, medication-related adverse skin reactions, which was very interesting to learn about when I became involved with the Visiting Nurse Faculty Program, and of course pressure injuries, which are always a risk for people as they become more immobilized, particularly in result of pathology. So what are we going to talk about today? We're going to talk about skin and wound issues, particularly how Parkinson's disease affects the autonomic nervous system. We know it affects the sympathetic branch, we know it affects the parasympathetic branch, and we know it affects the enteric nervous system, which innervates the GI system. And I just heard a wonderful presentation on the implications of Parkinson's disease for GI function. It's all related to this pathological protein called alpha-synuclein. So Parkinson's disease does have an impact on the cardiovascular, GU, GI, and motor systems. And it's kind of linked together by this issue of dopaminergic neurons. We have these neurons in the brain that are pigmented by melanin. And there's some suggestion that the same melanin, a related melanin that is associated with melanin formation in the skin, is somewhat related to these dopaminergic neurons in the brain. So we know that alpha-synuclein is present in neurons in the nervous system, but also in the skin, which is an interesting relationship. And you're starting to see more and more publications occur about how the skin can be used for diagnosing Parkinson's disease early on. So we know Parkinson's disease alters the integumentary system via cutaneous denervation. Parkinson's disease affects the neurons innervating the skin, so people with PD have altered thresholds for cold, warm, and pain sensation. But interestingly enough, Parkinson's disease also alters something called microRNAs. Now, these are small endogenous non-coding RNAs as opposed to DNA. And these microRNAs regulate other protein-coding genes. And you say, well, why is that important? Well, microRNAs play a role in skin morphogenesis. That's the 10-cent word for saying how skin is formed. They also play a role in skin carcinogenesis, and that's where it links into a malignant melanoma, which we're going to talk about in a little bit. And also, microRNAs influence the inflammatory response. The inflammatory response is necessary for wounds to heal. After somebody is wounded, the first thing that's addressed by the body is stopping bleeding. But the second response is cleaning up the wound. So theoretically, these microRNAs that are altered by PD can play a role in wound healing and affecting it whether you're able to heal as quickly as normal. And the bottom line is there is this whole emerging phenomenon called epigenetics, where there are changes in gene expression. And Parkinson's disease may, through its influence on microRNAs, affect how genes are expressed. Not changing the genetic code, but how they are expressed in the body. So more clinically, some of the issues related to Parkinson's disease in the skin relate to these topics that are listed on this slide, specifically seborrheic dermatitis or other forms of dermatitis like incontinence-associated dermatitis or moisture-associated skin dermatitis, or hyperhidrosis, I had mentioned before, excess sweating, or sialuria, which is excess salivation, where you can have saliva affecting the integrity of the skin at the corners of the mouth on the face. Okay, let's talk about a very serious issue, Parkinson's disease and malignant melanoma. It was thought originally that some of the issues that were associated with melanoma were related to some of the drugs that are used. We're going to talk about that in a little bit. But we know for a fact, in addition to malignant melanoma being a critical skin issue, and there is a picture right there of a melanoma, if you think about the ABCDE mnemonic, where it's asymmetric, it has an irregular border, it's multicolor, it's larger than the head of a pencil, larger than 6 millimeters, and it's elevated and it's enlarging. That's the ABCDE mnemonic. That's the worrisome signs of a potential melanoma. But you can also have medication-related skin reactions, and we're going to talk about them in a little bit. And as I mentioned before, pressure injuries, a tremendously important focus now in assessing quality of care. Certainly, nurses have been focused on this for several years, and you're seeing more and more regulatory focus on pressure injuries. So let's talk about seborrheic dermatitis. First described in Parkinson's patients in 1927, not a new issue. How is it presented? It shows up as a greasy facial skin appearance. It's associated with reddening or erythema and scaliness. It's located in areas where there is rich sebum, like the scalp, the face, eyebrows, nasolabial folds, the upper chest. Wherever there's greater oiliness, that's where sebum-rich areas are located. And interestingly, greater oiliness occurs with greater disease activity. The mechanism of that relationship is unknown. However, if you look at the research on this, the prevalence of seborrhea in Parkinson's disease patients is as high as 52 to 59%. So it's something that people that are looking at the skin of PD patients should be considering. So how do you treat it? Variety of ways of treating it, and I've included some trade names, not because I have any stock in any of these things, but for recognition purposes. You can treat the skin with topical steroids like hydrocortisone or topical antifungals, things like ketoconazole. But there are also dandruff shampoos that work very well in treating the expression of the excess sebum in the scalp. Interestingly enough, seborrhea and seborrheic dermatitis improve with dopamine therapy. It gets worse with increased disease activity, and it improves in response to PD medication therapy. You can also use another newer form of topical therapy called topical calcineurin inhibitors, like tacrolimus or primacrolimus cream. They work very well, steroids and topical antifungals are used more commonly. So what are some of the other forms of dermatitis one might encounter in someone who has Parkinson's disease? Things like incontinence-associated dermatitis. The risk increases substantially with bowel and bladder dysfunction. It is notable that when feces and urine combine, it literally creates a different pH in the fluid that is lying in the perineal area. When feces and urine combine, the fluid that sits there is actually more basic. I always say, think about lye, pouring lye on the patient's perineal area. That is why people get very severe incontinence-associated dermatitis if the skin is not protected. But because of some of the skin disorders that are associated with Parkinson's disease patients, you can have moisture-associated dermatitis. It can be associated with excessive sweating, the hyperhidrosis, or excessive salivation, the sialorrhea. So you can also have another presentation if someone with Parkinson's disease has a percutaneous feeding tube. And some of the intestinal gels may be, the medications may be given via a PEG tube. So possibly you could have some form of moisture-associated dermatitis associated with some kind of percutaneous tube. Another issue is this issue of hyperhidrosis, a called general category of dyshidrosis, because sometimes people don't have not just too much sweat, they can also have too little. Hypohidrosis, or too little sweat, is not as common. Hyperhidrosis can be up to 60% of Parkinson's patients. It often precedes motor symptoms by 2 to 10 years. The most common affected areas are the head and the trunk, and it becomes more prevalent with disease progression. Some studies suggest that excessive sweating worsens with poor disease control, off periods when medications aren't working, and when dyskinesias are displaying. And one of the things which has an A-level recommendation, which means really solid research support, is the use of botulinum A toxin, or Botox, for axillary sweating. It's literally sort of paralyzing the sweat glands in that area. That would be someone who has a very serious condition when they would move to that. Sialorrhea, the excess salivation, can be, of course, distressing to a patient. And they also can have an accompanying difficulty in swallowing. So it's a challenge for patients' quality of life. This can also respond to the use of botulinum toxin, and it also tells us in terms of how to protect around the mouth. One has to be careful in how to do that. One of the things that has to be avoided in using anything near the oral cavity is any kind of skin protectant that has any kind of oil or petrolatum base, because there's a risk of aspiration. And lipoid pneumonia related to that has occurred. So if this is really severe, it might involve requiring drug therapy. However, as has been mentioned before, the use of anticholinergics has to be very carefully considered because of their negative side effects in elderly patients. So it's interesting to find that sialorrhea can improve with a good response to drug therapy, levodopa particularly. So I mentioned before about malignant melanoma, very serious skin condition because of the potential risk to the patient's essentially safety, if you think about some of the negative consequences of having metastatic malignant melanoma. It's unsure if it is related to the disease process itself. Initially, that's what it was thought of. But recent research shows that there's an odds ratio of 1.83 of malignant melanoma in Parkinson's disease patients. More recent studies compared to ones done in previous decades show it's not the drug therapy that's a risk factor, but the Parkinson's disease itself. And I'd mentioned before there's a possible link between alpha-synuclein and melanin. Alpha-synuclein, which becomes aberrant, becomes abnormal in Parkinson's disease, is involved in both melanin synthesis and the dopaminergic neuronal cells that are affected when Parkinson's disease develops. So it's different from the melanin that's in our skin, but there's some relationship. You say, well, what's the clinical implication? The clinical implication is that Parkinson's disease patients need a thorough skin assessment done at least yearly to assess for the presence of malignant melanoma. Medication side effects can also be pretty severe. Levodopa and malignant melanoma, I mentioned before, likely not related. It's probably related to the disease process itself. But there are other drugs that are used in Parkinson's disease that can affect the skin. Apomorphine can cause skin necrosis or skin nodules. Another drug, not as commonly used, it's one of the third degree or third level type of drug that might be used, amantadine, otherwise known as Simitrel, is associated with a condition called livedover reticularis. And there's a nice picture on the slide that you can see. It looks almost like mottled skin or fishnet stockings. It's usually in the lower extremities, although it can affect the upper extremities, and it's likely related to interruption of blood distribution in the dermal arteries in those extremities. So if this becomes severe enough, it may require drug discontinuance. So there is suggestions for dealing with apomorphine therapy if people develop skin nodules. They recommend rotation of choice of the infusion sites where they're injected, use of Teflon needles, altering the angle of the needle to the skin, maintaining good skin hygiene and using emollients at the infusion site, choosing a lower concentration of the drug therapy, massaging the site. They even showed the use of using a spiky rubber ball or some kind of vibratory device over that area to help the drug disperse. Ultrasound has been suggested, and also silicone gel dressings. And these citations are listed in the references at the end if you'd like to explore this information more. Some of the drug therapy that's used in Parkinson's disease because of some of the effects on the GI tract, some of the drugs are applied through transdermal skin patches. And skin reactions can occur with these patches. Particularly transdermal selegiline and rotigotine have been used with adverse skin reactions reported. Rotigotine particularly is used in Parkinson's disease. Selegiline is usually used in major depressive disorders. But it's important for nurses and other people to know that these medication delivery systems can cause adverse skin reactions, rashes, and some kind of irritative response. And lastly, mobility issues with disease progression and the relationship to pressure injury. We used to call them pressure ulcers. The National Pressure Ulcer Advisory Panel in 2016 recommended we change the term to pressure injury. They are related to increased pressure on bony prominences, the inability to reposition oneself as mobility declines. If there are issues with cognitive decline, that can also be a factor. And then, of course, the risk of fecal and urinary incontinence because of the impact on the skin. So, as I'd mentioned before, pressure injury has become a very hot topic. It is important for the patient's quality of life, and it is important for everybody providing care for Parkinson's disease patients to consider some of these factors. Are these the only factors generating pressure injuries? No, but they are primary factors altering the situation. So I find this fascinating, the impact of alpha-synuclein and its impact on the autonomic nervous system, particularly in the skin. There is research showing that higher levels of alpha-synuclein, the abnormal, the aberrant protein that's found in the neurons of Parkinson's disease patients is also found in skin of Parkinson's disease patients in higher levels. So there is discussion now in the literature talking about the potential for skin biopsies to be used early on for Parkinson's disease diagnosis. So it's a potential for a premotor marker of Parkinson's disease in the future. So stay tuned to see more research related to that. So just to summarize, Parkinson's disease non-motor issues definitely affect the skin and integumentary system, and the Parkinson's disease skin issues associated with drug therapy are prevalent. You need to recognize them when you see them, and it's not necessarily that you have to discontinue the drugs. You may need to alter a different format, but the skin manifests some drug reactions, and it's important for us to be aware of that. And listed after that for the next couple of slides are the references that I've used in this presentation, and I'll send it back to Gwen.
Thank you very much, Dr. Beitz. That was an excellent coverage of the skin issues caused by the autonomic system, drug reactions, and other issues in Parkinson's, and very fascinating studies that you have done there. At this time, I want to remind everybody that we're going to be opening up for the question and answer period. Questions can be submitted by clicking in the text messaging box at the bottom left corner. Just type your question and then hit the send button. We will try to get through as many questions as we can. And we have some to start off our question and answer period. This is a question for Joan. Joan, we had a question from the audience regarding why would one want to avoid hot showers and baths in someone with Parkinson's disease who has orthostatic hypotension?
Sure, that's a really great question. It's just the warm water will dilate the blood vessels, thus leading to a much more potential of somebody feeling dizzy or lightheaded. And so it's really just vasodilation due to the warm water, which we don't want, of course.
Thank you very much. A question came in for Janice. Dr. Beitz, is hidradenitis suppurativa associated with Parkinson's disease?
That's a great question. It is associated, it's actually called acne inversa. I have not seen a higher rate of hidradenitis suppurativa in PD patients, but I have not researched that. I have taken care of many patients with hidradenitis suppurativa, and I can tell you at the end of the day, what you have to do is remove the glands that are affected. You have to cut them out. You have to usually use some form of negative pressure therapy to help heal the area that's affected. It's usually the axillae and the groin areas, the sweat glands that are they're very inflamed. They get secondarily infected. Does it have a higher rate in Parkinson's disease? I have not seen it in the literature, but I promise I'll look it up and I'll get back to Gwen.
Okay, so thank you very much, Dr. Beitz. I have not heard of it being related either. Have you, Joan?
I'm sorry, I missed the question.
Oh, I'm sorry. There was a question from the audience if hidradenitis suppurativa was related to Parkinson's disease.
Yeah, I have not seen it.
Okay.
I'm not the expert. Mm-hmm.
Oh, okay. We have another question here for Joan. My family member with Parkinson's disease is on a medication to lower his blood pressure. What do I need to be concerned about? You were talking about orthostatic hypotension and low blood pressure.
Right. So, because of the autonomic nervous system innervation and the potential for low blood pressure due to ANEF involvement, but also the side effect of low blood pressure from Parkinson's disease medication, it really is prudent to keep an eye on the actual blood pressure readings, remembering that a reading might be low, but somebody might be asymptomatic. So I think if I were this family member and my loved one was on PD medicines but also high blood pressure medicines, I would ask at the doctor's office for the person taking blood pressures to go ahead and check sitting and standing blood pressures. I think that family members need to certainly advocate for their loved one, but it's also an opportunity to really teach a health professional who might not have an awareness of the unique care needs in Parkinson's disease, might not know about orthostatic hypotension. So if the blood falls, that 20 millimeters for the top number or 10 millimeters for the bottom number, and is symptomatic, then the doctor who's prescribing the high blood pressure medicine and the neurologist need to connect to have a conversation about this new symptom. If the loved one has a low reading but is not symptomatic, not dizzy, lightheaded, feeling lethargic or foggy thinking when they're up, it's really watching it and making sure that loved one is drinking enough fluids and doing everything that they can to be safe, moving their legs before they stand up, those kind of things.
Thank you very much, Joan. Janice, a question from the audience for you. How is livedo reticularis treated? That's the rash that some folks get from the amantadine or the Simitrel.
Usually the treatment is drug discontinuance if it's bad enough. You can have a mild response. If it's severe, like it was in that picture, if it's lower extremities, upper extremities, you have to stop the medication. That's the therapy.
Right. Okay, very good. One more question for Joan. Joan, you mentioned that Reglan is contraindicated in Parkinson's disease because it blocks dopamine. Are there other medications that one should avoid in Parkinson's disease?
Yeah, Reglan is the big one. The other really often used medication is haloperidol or Haldol that might be used for hallucinations or psychotic symptoms. Haldol is also a dopamine blocker, so obviously someone with Parkinson's, given Haldol, their Parkinson's symptoms will escalate. There are a few other pain medications that are contraindicated if somebody is taking an MAO-B inhibitor type of medications for their PD or another treatment. But the really two big ones to remember are the Haldol and the Reglan, and also valproic acid. We have newer evidence that that medication also might inhibit, might be a dopamine blocker.
Hi, this is Janice. I just wanted to add in some of the antipsychotic agents that are dopamine blockers are also at risk. So as I remember, I'm pulling this from memory, but I believe quetiapine and clozaril are safer in PD patients. Not that clozaril is a safe drug to use because it's associated with all kinds of blood abnormalities, but there are only certain psychotropic agents that can be used safely in PD because of their effect on blocking dopamine.
Yeah, and the other, that's a really good thing to add, Janice, thank you. And there is a newer medication that is FDA approved for Parkinson's psychosis called pimavanserin or Nuplazid. So really three medicines, two mainly, that you're right, the Seroquel is most frequently used.
Thank you. Well, we're getting to the top of the hour, but we certainly appreciate our speakers today. That was an excellent presentation of all the nerve, autonomic issues in Parkinson's disease, and the good questions from the audience. Thank you very much for your questions. We have another webinar coming up on May 7th, 2019. Again, that will be at 1 o'clock Eastern Standard Time. And the topic of that Nursing Solutions webinar is Transitions in Parkinson's Disease Care. That really is going to discuss what happens to patients when they transition from home to hospital, or hospital to nursing home, or hospital to skilled nursing facility, or rehabilitation center back to home. There are many implications for nursing care during that transition time.